Tonight we are here for our Parenting U session on preparing for a newborn. Your speaker tonight is Steven Sindelar. He is a pediatrician with our Children's Physician's Office located in Bellevue. He has quite a bit of experience as a pediatrician and as a parent, so not only can he give you some of that practical clinical advice, but he can tell you the hands-on, down and dirty from a parent's perspective as well. So
I hope so.
That's right. Yeah, you can.
Yeah.
So without further ado, I'll give you Dr. Sindelar.
Well, thank you very much for coming. I think it's actually, is this the biggest crowd we've had, or no?
It's one of the few, yeah.
Yeah, we've had quite a few people sign up, so I appreciate everybody coming out. And hopefully I can give you some good information on your exciting time that's to come here soon. Is everybody first-time parent? Nobody's a second time? Good. So I can say whatever I want, and you guys will believe me then, I hope. Very good. So let's get started, and we'll go to the first slide. Now, feel free to ask questions. You can write them down, but if you want to go ahead and ask and interrupt, by all means, if you can't wait, go ahead and ask. I have no problem with that, rather than necessarily sitting through the whole slideshow. So if you do have a question, you can interrupt the slideshow. All right, so we'll start kind of at the beginning here. How many have already chosen a doctor to go to? Has anyone done that yet? So it looks like, maybe a third to a half have already done that. Did you guys, how did you decide that? Did you ask friends? Did you throw a dart at the little provider book or the OB? Most people, I would say, when they're choosing a pediatrician, it's mostly word of mouth. So they're usually asking family, friends. It's amazing in my office how many people I find out like 4 or 5 years later that they're related to somebody else in my office, or they're good friends with somebody, or they work with somebody. So really that's going to be your main source of finding out where to go. Later on that slide, talk about the getting to know you visit. You can get some information from that and get an idea of the personality of the pediatrician, but really it's nice to talk to somebody who already goes to the practice and get the idea of what kind of really goes on from a parent perspective. So that's definitely probably one of the main sources. And then the next would be an OB. Sometimes the parents will just ask their OB who they recommend or who they like to go see, and I think that's another good source of information. The insurance providers, if you have somebody you're going to who's pretty well established, you can be pretty comfortable in knowing that they're probably covered by your insurance. Back before the big websites, they used to have all the provider books, which I still think they have. And a lot of times some of the newer providers won't be in the book. And so I know when I first got in practice, a lot of people, I lost some patients because they thought I wasn't on their insurance. And they would actually call the insurance company to talk to somebody to see if I was on the list. And basically what they would do is open up the same book they had at home, and they would look at it and they'd say, oh, yep, nope, they're not on the list. But actually the best place to ask is just call the office you're thinking about going to, because most offices, really know what insurance plans people are on. And right now, I'd say about 50 to 60% of the plans are all Blue Cross, Blue Shield, or United Healthcare. And I can tell you most people are on those plans right now. So now, has anyone done a getting to know you visit yet? Met someone yet? Yeah, those are really important. I think it's important from your standpoint and also from the doctor's standpoint. It's really nice to get to know you people before everything happens. Sometimes we don't always remember you when we get to that first day in the hospital, but I think it's really important to get an idea of whether you're going to click personality-wise. Because I think most pediatricians, most physicians are competent, they do a good job, and I think it's more of an issue of connecting personality-wise and being able to communicate with your doctor, because it's a very important relationship. And I think that's it's important that you get a good start, and I think the getting to know you visit is a good way to go. The questions, I get kind of the same questions or no questions, depends who's asking. They ask about hours and what do we do after hours, and what do we think about breastfeeding, stuff like that, which is all important. But the main thing you really need to get down to is what happens when my child's sick. I mean, what happens during crunch time? So for example, if my kid's sick at 4:30, are you going to get me in to be seen late in the day, or are you going to send me to an urgent care? Another important question is, well, if you're too busy that day, do I have to see another provider, or am I always going to see you? I think that's really important to ask that. Some offices will just get everybody in. I mean, you may have to wait, but you'll get to see your doctor every time. Other people have nurse practitioners, PAs, things like that, which some people are okay with, but some people really want to see their own doctor, and I can certainly understand that. And then board certification and training. Has anybody investigated their doctor to see if they've had any issues? Or, most people don't look into that too much. If you look on most websites and things, most people are certified. And actually these days, most insurances won't put a doctor on their plan unless they're board certified. So you can be pretty comfortable in knowing that they probably are. All right, never too early to choose a daycare. Daycare maybe actually go before interviewing the pediatrician, because a lot of the daycares, especially the popular ones, the good ones, have a very long waiting list and can take quite some time to get into. So that's something, if you haven't done it already, is something you should look into. And as it says on the slide, there, different age limits they have. Certainly most of them do visits and interviews, so you can kind of get an idea of what's going on at the daycare. Different types of daycare. A lot of people ask me what I think is better. I think it just depends. Some people feel very comfortable with the larger daycares, and I think the advantage there is, one, you have several people taking care of the kids. So there's always people watching each other. You have a home daycare, especially if there's just one person. I think you have to be really sure you feel comfortable with that person. We've all heard horror stories about things that happen sometimes in home daycares, and I think you just have to make sure you're comfortable. Obviously the ultimate is if you can get a relative or a grandmother or somebody watch your child, but otherwise I think you have to really make sure that you feel good having your child there. People ask, from getting a illness standpoint, is there a difference? I would say in general, the larger daycares, you probably get kids, are going to get more ill just because there's larger rooms, more kids. But the home daycares, the disadvantage there is there's often kids of a lot of different ages going to those home daycares. So then you have kids venturing to school, venturing to preschool. They're picking up whatever's there, and then they bring it back to the other kids at home. The other thing I see too is the home daycares tend to be a little less restrictive on the rules. So if they have a sick kid and the mom's kind of begging, I really need to work today, the home daycares, they have a tendency to say, okay, I'll take care of your child. I'll just kind of keep them away from everybody else. And but the center daycares tend to be a little bit more restrictive and stick to the rules a little bit more. So those are kind of the plus and minuses with those. And of course, again, ask families and friends, just like anything else. Location, most people obviously pick something close to home or close to work. If something happens and they're at work, they can just zip over, pick them up. And it's nice if it's daycare's close and the doctor's close, and you can kind of take care of things in the same area, or stop by on the way home late in the day and take care of everything. All right, what do I need? Well, I think probably most of you have had enough baby showers and things like that. You've probably collected a lot of different things. And car seat is obviously the number one for us. And the main thing with that, there's various types of car seats. They're all good. Once in a while you'll get recalls and things like that. But for the most part, they're all safe and are going to do a good job for you. The one thing that's nice if you can do it is have someone who's trained show you how to put the car seat in the car to make sure it fits okay. Usually law enforcement personnel, sometimes firefighters, a lot of nurses take training in this. We have one nurse, I think, in our office who has taken the course. About 60% of car seats are put in wrong or aren't put in safely. And you think it'd be easy, it'd be straightforward, but it's difficult because all car seats are different, all cars are different. It's nice if you have a car with a built-in car seat. That makes it a little bit easier. But I thought that was something that would really take off, but I don't think that really has, unless you got the real high-end vehicle. I think sometimes those have them, but that's nice if you can do that beforehand and know how to put the seat in. And then the crib, obviously you want a nice firm mattress, sheets that fit well. You don't want something that's all soft. And again, I'll talk about this later with the SIDS. And the bumpers, it says no bumpers. How many have bought a bumper pad already for their crib? Bumper pads are decorative. I mean, they're okay to use. And this says no. I think you can have them, but once the baby can roll, you got to take it out of there because they can get caught up in the bumpers. So at the beginning, you can have it. Again, it looks nice. It's nice and decorative. But later, you're going to go ahead and take it out. And then a lot of people ask, well, won't they get their feet and arms and legs stuck through the little slats? Well, yeah, they do. But it never bothers them. You always see the kids wake up in the morning, their legs and arms are sticking out all over the place. But they don't ever have any problem with it. They usually don't wake up. They usually do fine. And most new cribs are safe. And if anybody, for some reason, has an old antique one, the issue of how far apart the little slats can be. Usually they say you shouldn't be able to fit a pop can between the two. Anything wider than that is probably too wide. Most people have something fairly new or something recent, so that's usually not an issue. But if you have something older, that's something you want to look at. Breast pump, that's something, it's hard because sometimes they can be very expensive. Some people aren't quite sure. Are they going to be in it for the long haul? Are they going to try it out? Are they going to maybe nurse, maybe not? Certainly there's hospitals and other places you can rent pumps, which is nice. But certainly if you think you're really going to use it, you're definitely going to want an electric pump, and preferably one that does both sides. It's going to cut your time in half. And if you're really going to do it for a long term, I recommend actually getting one as expensive as you can get, especially ones that have the cooler that goes with it. It just makes things a lot easier, not having to lug a whole bunch of things around. So I would definitely recommend doing that. Bottles and formula. Most bottles are fine. A lot of people will get into getting the ones with the liners or getting the ones that are kind of bent and angled. A lot of these companies claim that if you use their bottle, your baby's going to be less gassy, less fussy, things like that. Actually, the gastroenterology department here at Children's about 5 or 6 years ago actually did a study on the bottles and had people keep logs of how gassy and fussy their kids were, and it didn't make any difference what kind of bottle you used. Absolutely none. So you basically just, I think the bottom line is you find one, stick with it, kind of stay away from, buying several different types and jumping from one to the next, because it's probably really not going to make much difference as far as what kind you use. And formula, I'll kind of talk about that a little bit later. And then, of course, diapering and bathing supplies, things like that. Do they still make the diaper genies by chance? Does people have those? Yeah, I didn't know if they still had those. My daughter's a little bit older now, but I didn't know if they still made those. Those are kind of neat things to have. So, all right. So it's time to go. Mom's in labor. You're hanging out. You're at the store, counting contractions, things like that. So what do you need to bring? This is pretty straightforward. Obviously, you want to bring your car seat. You're going to bring all your little electronics gadgets you can't live without, cell phone. Most people bring a laptop now, so then you can take pictures, put them on, line, send them all over the internet and things like that. So things like that. Just, try to get it all in one shot if you can. And then outfits, of course. You see all sorts of nice little outfits. If you forget that, it's no big deal. It's not like they're not going to keep your kid warm and put something on that's going to be adequate. But most people want the outfit for pictures and to go home with and things like that, so don't forget that. And then weather-appropriate gear. Most of the time they have those little covers that go in the car seat. They have a little opening, a little hole where the baby can look out. Of course, that's good for colder and winter weather. As far as how warm to dress them, basically what you do is add an extra layer on top of what you would feel comfortable with. And that's the same for at home too. So if you're comfortable with just a t-shirt and shorts, t-shirt, shorts, and a onesie, basically. Your onesie is going to be kind of your extra layer. And it's important to have socks, hats, things like that to keep the head warm, keep the feet warm, and things like that. So just make sure you're bringing appropriate stuff with that. And then as far as checking in, they'll ask you who's going to take care of the baby. You usually don't have to call your office and let them know. They'll kind of handle all that stuff. Normally, when you go to the hospital, have a baby, normally there won't be a doctor at your delivery. If it's a regular vaginal delivery, even if it's a routine C-section, like I don't know if anybody has a breech baby. Anybody has one of those right now? Anything or failure to progress where labor's not quite going, usually there'll be no doctor there at the delivery. Usually the nurses are going to take care of it, and they're going to handle all of that. And then what they do is they call us, and then we actually round the next day, usually in most cases. So usually there's nobody seeing the baby right away. The nurses do all their assessments, and if they feel there's something wrong, they'll go ahead and call us. But for the most part, there won't be anybody there. Now here in Omaha, if there is something going on with the baby and the baby needs to be evaluated right away, or there's something with the pregnancy, usually it's going to be a neonatologist, depending on which hospital you go to, or a nurse practitioner who works in the intensive care. Those are the people usually attend delivery where there's worrisome things going on, or the baby's born and they're concerned about what's going on. Before the nurse practitioners, we used to go in for some of those things, but really that's a better way to do it because there's somebody immediately there. I mean, for me to drive in, it takes 15, 20 minutes, which doesn't sound like a lot of time, but it can be an important amount of time when it comes to a baby. So normally that's going to happen. And if for some reason your baby ends up in the intensive care, usually the neonatologist is going to take care of everything. So the general pediatricians probably aren't going to round on your baby or see the baby as far as medical reasons, but they may go up and check and make sure everything's okay, give you a call, visit in the room, make sure everything's okay. But usually we kind of let them take care of most of that stuff. And again, that's probably what you want. That's something they do every day on a daily basis. We do it once in a while. You want the most experienced person taking care of the baby when they're sick. So, all right. So after the baby's born, so everything went great, no problem, smooth, no discomfort, everything went great. And the baby's out, crying, ready to go. Now, these days, they do a lot more of, getting the baby dry, wrapping them up, and letting you be with the baby initially. It used to be you just kind of zipped them off, you put them in the warmer, took them to the nursery right away. Now they do a lot more of, put them on mommy's tummy, let them try to breastfeed, do a little bit of bonding right away, as long as everything's okay, of course. And then you do some of this stuff that they're going to do later. Now, initially, they'll do what's called an Apgar score. Now, Apgar scores were devised originally to give an assessment of how the baby is doing at a point in time right after delivery. To give you an idea, do I need to intervene or do I need to do something to either help this kid breathe, help the heart rate, do something, give oxygen, things like that. And they do those Apgar scores at 1 and 5 minutes of age. Now, it's a very subjective measure. So they look at things like how well the baby's breathing, the heart rate, how they respond to your stimulation, the color, things like that. So, and what you'll find is if you ask people what their Apgar scores on their kids, they're always 8 to 9. Almost always. In fact, when we were a resident, we had the target Apgar chart where you're supposed to just throw the dart and it gives either an 8 or 9. The 8 and 9s are real huge and all the other numbers are real small. And so most of you are going to get that. And most of the time you don't get a 10 because most babies' hands and feet are blue after they're born. So if they're blue, you can't get a 10. If you do get a 10, you got a superstar up there. So, but that assessment, there is a misconception that number means something later on. So a lot of times, if a kid is having issues later on, they'll wonder, well, what were the Apgar scores? If they're low, does that mean something bad? And actually, the 1 and 5 minute Apgar scores don't mean anything. You can have low Apgar scores and it has no prediction on, is my child going to have problems later? So really, they're not extremely important as far as that goes. Now, there's actually a 10 minute Apgar. If a child's doing not doing well at the 5-minute, you're supposed to do a 10-minute. Now, if you have a low 10-minute, then that does have some predictive value, which makes sense. I mean, the longer your child's going and having difficulty, that definitely will make a difference. And then the gestational exam is just purely a chart and has a bunch of different pictures on it. And the nurse kind of does a little exam, looks at some of the features like how well the ears formed, what the breast buds are like, what the private area looks like. There's all these different pictures. You mark the X's, you add up the score, and it gives you an idea what gestation they're supposed to be. So if there's any question on what's going, I'm not sure about my dates, things like that, it can kind of give you an idea of what's going on. And sometimes you can be sure on the dates and the baby can still look younger or older than your dates actually are. And then the initial nursing assessments, obviously you're going to do vital signs, pay close attention to the temperature, things like that. Respiratory rate, make sure that's okay. They'll do an initial blood sugar, and normally only one has to be done. And if the value is above 40, you usually don't repeat it, you don't recheck it unless the child has signs or symptoms of low blood sugar. Now, there's certain risk factors for having low blood sugar, and one is a big baby, so a very large baby, and the other one is if mom has either gestational diabetes or truly has diabetes. And it all has to do with insulin influence. When a baby's born big, it's usually because mom has a little extra insulin. And so what happens is the baby's carrying that with them after they're born, but they don't have any blood sugar supply from mom anymore. They have to generate on their own. And oftentimes as that insulin stays in their body, it'll drop the blood sugar down. So for bigger babies or with gestational diabetes, they'll often check several levels of the blood sugar just to make sure it stays up. So, and once in a while, you get a kid who just can't keep their blood sugar up. It's usually, again, a larger baby. Sometimes they're very small babies or preemie babies. They just don't have enough muscle to keep up their blood sugar. Sometimes they'll end up in the NICU for a day or two, getting some IV sugar just to keep their blood sugar up. And then usually it's taken care of and it's not a problem after that. Now, vitamin K and eye ointment. That's done shortly after delivery. The eye ointment is an antibiotic, and what that's for is there's certain infections and they're sexually transmitted diseases that can infect the eye and cause blindness. One's gonorrhea and the other one's chlamydia. So that's where that comes from, and it's still routinely done. In most cases, that's not going to be a risk, but obviously people aren't necessarily that forthright with their history, so it's something that's routinely done. The vitamin K is for what they call hemorrhagic disease of the newborn. And vitamin K, most of it in your body comes from your intestine. It's synthesized by the bacteria in your intestine, and then you absorb it. And babies just don't have that bacteria yet. And breast milk doesn't have hardly any vitamin K in it. Now, formula does, so formula can help keep the vitamin K up, but vitamin K is very important in clotting your blood. And if they don't have enough vitamin K, the risk is that they have bleeding they shouldn't have. And the two common sites that babies get it is either in their intestines, so they'll get blood in their stool, or more worrisome, they can get bleed in their brain. So it's very important that they get that vitamin K early on, especially if they're being breastfed. And then newborn screening, that's been around for quite some time. Newborn screening is a test they'll do just after 24 hours. It's a blood test. It's a foot poke. They have these series of filter paper. They basically just get enough blood to put little blots on the filter paper. And it tests for a number of things that, one, are difficult to diagnose until later, and two, need to be treated right away, otherwise they're going to cause problems. And the classic traditional one, which is the initial one they screened for, was low thyroid. Babies need thyroid for their brain to develop. If they don't have enough thyroid, it causes huge problems. And so it's obviously better to get that diagnosed early, get the treatment initiated. So that's something they're going to do. And now in most cases, they're going to do a standard newborn screen, which is mandated by the state. There's an extra one called a supplemental screen, which you don't have to do. You actually have to sign for it to be done. All it is an extra drop on another piece of paper, but they actually send it to Texas to be done. So it's classified as a genetic test, so you have to sign. You have to give consent to do it. I would recommend doing it, by the way, because it tests for a large number of disorders that, again, if you catch it right away and treat it, you can prevent complications later. Hearing screen, that started probably about 4 or 5 years ago. Before the hearing screen, about the average age of picking up a hearing loss in a child was close to 2. It's very difficult to tell if a young child's hearing or not. So this has been a great thing for us. The thing you have to remember about the hearing tests, and actually the newborn screen as well, is those tests are set up not to miss any cases. And whenever you set the parameters up like that, you're going to get a lot of what they call false positives. That means tests that are abnormal initially, but then when you do a recheck later, it's totally normal. And I would say on the hearing screen, probably 90+% of the time, the follow-up test is normal. So if your child doesn't pass the hearing screen, don't worry about it. It's very conservative to make sure they don't miss any kids with it. And that's the same thing with the newborn screen. Most of the kids that we get who have an abnormal screen when we do the follow-up test, totally normal. So you'll be worried about it, but you can feel pretty comfortable that the follow-up test is going to be okay. And then jaundice. Now that's not something they're going to necessarily check for right away. Jaundice is something that usually develops after 24 hours. And I would say most kids get jaundice to some extent. Now jaundice, the reason babies get jaundice is before they're born, they have their red blood cells, which carry oxygen, which are called fetal blood cells, have a real strong affinity for oxygen. And the reason that they're made that way is when the blood mixes in the placenta, it basically grabs all the oxygen off the mom's blood and pulls it off and takes it to the baby, which makes sense. Now, after the baby's born, they don't need those cells anymore. And so as those get destroyed or broken down very quickly, the bilirubin that makes you jaundice comes from those red cells. That's where that comes from. So what happens is they get this big rush of bilirubin, and it takes a while for their liver to figure it out. Now, you get rid of your bilirubin through your stool. So the more stools they have, usually the less jaundice they get. So, but that's why they get jaundice. Now, there's other factors that can increase their risk for jaundice. Babies that have a different blood type from the mom. So if the mom is O, or if the mom has a negative, the Rh negative, and the baby's either positive or has an O or a B, sometimes as the blood mixes, the mom will make antibodies to the baby's blood because it recognizes it as foreign. Those antibodies go to the baby, and what they'll do is destroy the red blood cells, even more than they are already. So those kids are at risk for having more jaundice. If a baby has a tough delivery, gets bruised a lot, obviously that destroys more cells that can cause them to be more jaundice as well. So premature babies, they can be more jaundice also. Now, as far as the physician assessment, like I said, we usually come the next day. Usually we come twice if you have a vaginal delivery, 3 times if it's a C-section. We come every day. We're looking at initially anything that's not quite right, when they're born, whether it's something that's obvious on their features, their heart, make sure that's okay. We examine their hips very closely to make sure their hips are formed right. That's especially important with breech babies. But it's basically just head to toe everything, make sure everything looks right, make sure everything's okay. Yeah. Oh, what they do is they have these little electrodes, and they put them in the ears, and basically all it does is it sends a signal to the eardrum, and it makes it move basically, and then it bounces off, comes back, and it has a receptor on there, and it picks that up again. And that's how they test that. Now, the baby has to be quiet to do that. So sometimes babies are moving around, or sometimes babies have a little extra wax or something in their ears, and they can't get an accurate test. That's probably the most common reason they fail. But that's what they do. It's kind of a neat little test. They usually do it right away, kind of the first day they're born, and they get that done. So it doesn't hurt. It's not painful, obviously, or anything like that. They do fine with it. So, all right. So considerations: breast or bottle. Obviously, as a pediatrician, I support breastfeeding. It's a good thing. A lot of benefits, but it's not everything. I'll tell you that. When we have breastfeeding moms, we support them 100%, but not to the point where they're going to be guilty if they can't do it. There is a certain percentage of moms who are not going to be able to nurse. Either not at all, they're not going to make any milk, or they're not going to make enough milk and they're going to have to add formula to the feeding. Just to let you know that. It's very common, especially first time, to need a period where you're actually giving a little bit of formula until your milk comes in. So often you need to do both. And there's no reason you can't do that. A lot of people have a mindset, well, I have to breastfeed or formula. No, you can do both. And that's very common to have to do that. Now, obviously, the disadvantage of the bottle feeding is the formula is very expensive and it's not getting any cheaper. Some kids are sensitive to the formula or don't tolerate it very well is another disadvantage. They definitely tolerate breast milk much better. The advantage of formula is they don't eat as often, which is not a huge deal, but when you're up 3 or 4 times a night, it may be. And then what formula to use? There's many different types. Now, I have to ask, is there any formula company reps in the audience? Anybody? Before I say this? People will ask, are all the formulas the same? Because you'll go there and there'll be a ton of formulas, and there'll be Enfamil, there'll be Similac, there'll be Nestle Good Start, there'll be Parents' Choice, there'll be a Target brand, there's a Hy-Vee brand now, and basically they're all fine. If you look at the ingredients, there's small differences, but for the most part, those formulas are fine. Most people will use the name brand ones, but a lot of people are going more towards the store brands, and they're going to be okay. I wouldn't worry about using that type of formula. And there's different levels of formula. You have your standard formula, which where the protein source comes from cow milk. Then there's soy, of course, where the protein source comes from soy. And then there's special formulas that are pre-digested where the protein's broken down into smaller pieces. And then there's super special formula, which actually just has straight amino acids, and that's it. And all those formulas have to do with what they call MSPI, or milk soy protein intolerance, which I think I have on a slide later on, and we'll talk about that. And then breastfeeding, when will your milk come in? According to the book, they'll say 3 days to keep you optimistic, especially the first time. Could take 4 days, could take 5 days, could take a week, could take longer. Sometimes it takes a long time for your milk to fully come in. So you just have to be patient with that. Now, sometimes it will come in 3 days, and that's awesome, but be prepared to go a little bit longer with it. And that's why I say sometimes you have to do the formula with it for a while. Sometimes babies will lose a little extra weight, get a little jaundice, you need to get them a little extra fluid. Sometimes you have to bridge that gap until your milk comes in. Now, if you have second, third, fourth baby, your milk's going to come in faster. So if you have a C-section for some reason, that's going to delay your milk coming in as well because it's a stress to your body. So probably delay it by a day or two even. So supplements, we talked about that. And then lactation specialists. Now, a lot of the hospitals have good lactation specialists, and a lot of them advertise their program. To be quite honest, though, when you really need your lactation specialist is when you go home. And unfortunately, a lot of the hospitals don't have great outpatient lactation services. There's some private people that do their own counseling, but a lot of the hospitals will only consult you by phone. So it's very difficult. Some doctors' offices will have some nurses that will help out too. But and certainly in the hospital, it's nice to learn how to get the latch going and things like that. But it seems like most of the issues happen when you get home. So and Methodists definitely have a good lactation service. Their outpatient service is very good, and so on. Pacifier, that's something that the lactation nurses will tell you no because it's going to cause nipple confusion. Same thing with supplements. I think that can happen to some extent. I think when that does happen, that's normally in a child who's having trouble to begin with from the get-go. Sorry, guys. I think most babies can do both and do them just fine. Now, pacifier, it's nice if you can get by the first few days without it while you're working on the nursing, but I can tell you there are some babies who absolutely need a pacifier. Now, I'm not a big fan of it. I didn't give it to my kids. But there are some kids, if you don't give them a pacifier, you're going to be the pacifier. And you don't want to be the pacifier. Because not only are you going to nurse every 2 hours, but you're going to be putting your kid to the breast in between because they want to suck all the time. And so there are kids who need that pacifier just to give you a break. And I can tell you, most kids, if you give them a pacifier and they don't want it, they're probably hungry. So you're not going to suppress their appetite or anything like that by giving a pacifier. So some kids need it. I don't have a huge problem with it as long as it's gone by the time they're 2 years of age, at least, if not sooner. Once you go past 2 years, then you run into a lot of dental problems, so you want to get rid of it by then. All right, circumcision. Who's having a boy? Does everybody know? Almost everybody know? Does anybody not know what they're having? All right, good work, guys. So,
Find out tomorrow.
don't do it. Circumcision. Now, the decision really is up to you. There is no true medical reason to get a circumcision done. There is a slightly higher risk of getting urinary tract infection in the first year of life, but after a year, that risk goes away. So most of the people obviously get their kids circumcised. It's for cosmetic reasons. They want everybody to look the same in the locker room, look like dad, whatever. I think that's reasonable. But medically, there's no reason to do it. And for a while, we actually saw a trend of more people not doing it, but then it kind of went away and people went back to doing it. There are some ethnic groups that tend not to, like Hispanics in general will not circumcise. But the only risk you run with not circumcising when they're young is having to do it later. Once in a while, you get a kid who will get an infection of the area, or the foreskin won't ever pull back, and they actually have to be circumcised. I've had a couple of kids when they're 8 get circumcised. It's not very fun, or at least it doesn't look like it's very fun. So it's obviously much easier to do when they're small. And there's basically 2 different devices they use. Most people in this city use a Gomco. They call it kind of a big metal. I don't want to say it's medieval looking. That sounds bad, but it's kind of an interesting looking device. And there's a thing called a Plastibell, which is up there. Plastibell you probably won't see around here. Now, most circumcisions done in town are done by the obstetricians, not the pediatricians and the family practitioners. And so you can ask if your doctor's going to do it, but most OBs do it. They have more surgical experience, so for me it makes sense. Now, it used to be nobody used anesthesia, or very few people used anesthesia. They would go, the OBs would argue, well, we do it so fast it's not going to be that big of a deal. So they would just do it real quick and that's it. There are some hospitals now that actually mandate you have to use some sort of anesthesia, which is either going to come in the form of an EMLA cream where they put a topical on for a while and then do it. And then they usually have the baby suck on some sugar water, which they found eases their discomfort. Or they use an injection, which you can numb it up by just injecting it and then do the circumcision. And the care is fairly easy. They actually heal. It's incredible. You can see some circumcisions that look absolutely horrible. And it's going to look red, it's going to look angry and irritated. I mean, it looks like it really hurts. But those things heal. I can't believe how well they heal. And the other thing I'm actually very surprised is I've never seen one get infected. I mean, you would think if you took away the skin, it was that irritated, it's down there with the stool, it's down there with the urine, this is going to get infected. I've never seen one get infected. What you're going to see as it heals, there's going to be like a yellow film that forms on it. And that's normal. It's what it heals like, and this is going to probably make you feel bad too, is it heals like a burn does. So if anybody's had a bad burn, you get that kind of layer that forms over the top of it as it heals. That's basically what it looks like. And so, but eventually it looks great, looks fine. The other thing I'm going to let you know about circumcision is later on, you're going to get what's called, not everybody, but most, the buried penis syndrome. And what happens is, when the foreskin's there, it's attached to the end and it keeps everything pulled out. When you take that away, it sucks in. And of course, all babies get that big fat pad down there. And so what you see is nothing. And like a little turtle goes in, everything covers back over the top. Now, later on, when they go through puberty, everything will lengthen out and everything stretches out and the skin stretches out and it'll look fine. But a lot of people ask, well, is circumcision done wrong? Well, no, it was fine. That's just what happens. So. All right, so let's go to this one. Okay, so you think you're ready to go home, or an insurance company. That's actually not so bad anymore. Back with the HMOs about 10 years ago, there was this huge push to get all these people out at 24 hours because they claimed that it was safe. It's not. There's a lot of things that can show up after 24 hours, very bad things that don't show up before then. The biggest one, and I won't go through them all, is heart problems. Oftentimes there's no heart murmur, no evidence of anything. All of a sudden, 3 or 4 days later, your kid can crash from a heart problem. So it's really important, I think, to stay that second, third day. The other thing that I think is important is, the mom at that 24-hour mark is still on her high from the delivery. She's been through it, she's feeling good, she has a new baby. It's that second or third day when you start dragging a little bit. And I think it's nice to have that extra day to relax, kind of let the nurses take care of the baby a little bit, just get that little extra day's rest. And I think that's especially important once you have your second or third, because you have this toddler at home or an older child at home. They want your attention. I think it's just nice to get that extra day and to get a break. And then again, like I said earlier, C-section is an extra day there. Home health visits, usually we do those if we have a young single mom. If we have a child on phototherapy, they'll come out and check the weight and sometimes draw the follow-up lab tests, things like that. So home health visits are something we sometimes do. All right, first office visit, 1 to 2 days after discharge. Sometimes we'll go longer than that, but these days, especially with breastfed babies, we'll usually see you shortly after you go home. And that's mainly to check the weight, make sure they're not getting dehydrated, make sure they're not too jaundiced, make sure the feeding's going okay. Sleep, I can tell you that's not going to be regular for quite some time. So the main thing we target on the sleep is that we get out of that day-night mix-up. So a lot of kids, what they'll try to do on you is they'll stay up all night, especially that second night in the hospital, and your temptation the next day is to sleep and let your baby sleep. Well, if you do that, next night's going to be the same thing. It's going to be up all night. They're going to try to sleep on you the next day. So really what you need to do is just make a concerted effort to wake them up every 2 or 3 hours during the day, even if they're real sleepy, just to get them in that habit of waking up more frequent during the day. And eventually they'll turn around to some extent. Now, I can tell you, nursing babies often nurse 2 or 3 times through the night for a long time. I mean, it can be quite a bit of time. So be prepared for that. Now weight, they can lose up to 10% of their original weight. So a big baby can lose up to 1 pound and it can be normal. Littler babies, it's going to be more like 10 to 12 ounces, somewhere in that range. So that would be a case where if we had a child who's losing a little too much weight, where we're going to say, okay, I know nursing's going okay, but maybe we need to add a little formula for a few days until your milk comes in, get that weight back up, and get in the right direction. And then normally after that first visit, we'll see you about 1 to 2 weeks after that. And of course, we do a full physical exam at that point. The hip ultrasound, that's on there for babies that are born breech. We always do hip ultrasounds on them, even though their hips feel fine. The big risk factors for having hip problems in babies are being born breech is number 1, and then there's the 3 F's. Females are 10 times more common. Firstborns are 10 times more common. And then a family history. Someone had it before. So if we get some risk factors, we'll usually do that ultrasound around a month of age, send you up to the hospital. It's not painful. It's just like an ultrasound you get prenatally. They just do it on the hips, move the hips around, make sure everything's formed right. All right, now the biggest threat to your child when they're young is going to be infection. So, what do you look for? What are the signs of infection? Now, obviously fever is going to be one. And fever of 100.4, that's done rectally. We always like rectal temperatures in little kids. You're not going to cause any harm by doing it. Nobody's using glass thermometers anymore. They do make some digital ones that are kind of wide and got a thin tip on it. So it tells you exactly how far to go in. So you're not going to stick it in too far. They read in 30 seconds or so. If you do it in another way, call your doctor. They're probably going to say, we'll check it rectally so we get an accurate temperature. But 100.4 or higher. Now, some kids we see have 100.2 or whatever, and they're showing signs of either illness. Well, we're not going to argue about whether it's 100.4 or 100.2, but that's a kind of a general guideline of what we have for temperature. Now, some kids will actually get sick with an infection, get low temperature too. So that's why we have that lower one there, 97.4. And again, that's a rectal temperature. But the number one sign you're going to get that your kid's sick is they don't want to eat, by far and away. Kids, unfortunately, have very nonspecific symptoms when they get sick. So, it's not like they're going to tell you, my head hurts, I have a headache, my lungs are bad. They're just going to not eat. They're going to look bad. They're not going to feel good. So that would be your number one thing. And my recommendation usually in kids after they're born is that you have very limited travel or contact with big crowds up to a month of age. And the reason I pick a month of age is a child who gets a fever less than the month of age is almost automatically going to end up in the hospital. They're going to get blood culture, cath to get a urine culture, and they're getting a spinal tap. And they're going to get put on antibiotics until they don't have something bad, because they don't show you any specific signs. And a small child can go from being a little bit sick to very sick in 12 hours. So it's nice to make sure they don't, aren't around other people getting temperatures. Because I can tell you most kids that get sick under a month of age are going to have a mild virus, but you can't bank on that. I mean, you can't wait it out and see if they get better, because they'll get sick fast. So you have to check them for all those things. I think once they're past a month of age, you can go ahead and start to do more things, get out and about and stuff like that. And I understand there's family members who want to see the baby and stuff like that, but you have to be a real stickler when it comes to keeping sick people away. A mild illness in an adult can be a serious illness in a kid, especially during the winter season. And we all know about H1N1 now. It's been all over in the news and other illnesses like that. So you have to be really careful with all that. And keep those sick people. You can blame it on the pediatrician. You can say, pediatrician told me that. And of course, good hand washing is obvious there. Feedings, we talked about this, every 2 or 3 hours for breast milk, 3 to 4 hours with formula. The bottles, we talked about the different type of bottles. The bisphenol A is it was in the plastic of the bottles. There's a big thing about that not too long ago as far as causing hormone problems and things like that. I think most of that has been taken out of the bottles now. All right, spitting up. I can tell you a majority of babies are going to spit. And some are big spitters, some are little spitters. We have a few kids who just barely spit up once in a while, but most kids are going to spit up, and probably more than you think they are. Now, spitting up is kind of like blood. You take a drop of blood, you drop it on a sheet, looks like there's a huge amount. Spitting up is the same thing. People will tell us, my kid's spitting up all my feedings. I mean, they were spitting them all up. And we bring them in, and they've gained like 2 pounds in a week. It's like, I don't think your kid's spitting up all they're eating. But most kids are going to spit up to some extent. So if you have a kid who's spitty, it doesn't cause them any breathing problems. They're fairly happy. They're good eaters. No other symptoms. They're just the happy spitter, we call them. You can try to slow it down by keeping them more upright after the feedings. Sometimes you can elevate the bassinet or the crib a little bit to keep their head a little bit higher, things like that. But for the most part, they're going to do fine. And they may spit for 6 months or so. They'll eventually outgrow it. It just disappears and goes away. So just have a big laundry bill. The worrisome symptoms with spitting on that list there, projectile vomiting. Obviously, if it's shooting across the room, that's not going to be normal. Most spitting is just barely coming out. If there's any blood or bile in it, bile is the number one thing you worry about. If you ever have green stuff that's in the spit up, you call right away, no matter what, because that's a sign something's being obstructed, and obstructed intestine in a small baby like that is an emergency. Something usually you'd have to go to surgery right away. So anything like green color in there, you need to worry about. Poor weight gain, that's our job to figure that out. So that's why we follow them up very frequently when they're young, make sure they're gaining weight okay. If a kid's spitting up and gaining weight, well, it's unlikely that they have a major physical problem. Fussy kids, now that's a little bit touchy because everybody has their own idea of what fussy is. I can tell you can have 2 babies with the same amount of fussiness. One set of parents will think it's just regular. The other parents will call us every day about it, thinking there's something wrong with their kids. So really that depends on how fussy they are and when they're fussy. If you have a kid who's fussy all day long, constantly, can't ever get them settled down, and they're spitty babies, that's something that probably needs to be looked at. The most common, one of the most common diagnoses we get as far as fussy babies is reflux. I don't know if you know friends who had their kid had reflux and had to be on Zantac or some medicine. Again, the other one was MSPI. Talked about the myxoid protein intolerance, which can cause a lot of fussiness. But in general, extremely fussy kid, you look at possibly doing tests and treating. If they're mildly fussy, not so much. If your kid has classic colic, which is, they get up at the same time, or they are fussy the same time every night, it's usually the parents tell us, well, from 7 to 10 o'clock every night, they're fussy, they're irritable, so on. The rest of the day, they're perfect angels. That's your classic colic. That usually starts about 3 weeks of age, goes away about 3 months of age, disappears, never comes back. And reflux goes away. MSPI goes away. They all get better with time. It's just treating them until their major fussiness goes away and they outgrow it, and then you stop the treatment, go from there. And then breathing problems, I think, is fairly obvious there. Stools, I won't go into that too much. The meconium, dark black sticky stools, looks like tar. Usually that goes away after hopefully 2 or 3 days. And then breastfed stools are more of a seedy yellow mustardy colored stool. Formula-fed stools, I wouldn't call them necessarily tan. I'd say they're more kind of a greenish yellow for the most part. Sometimes they're tan. They should always be soft or almost mushy. The breastfed stools will be very loose. A lot of times you get a little bit of stool with a lot of water is absorbed into the diaper around it, a big ring of water. That would be pretty normal. Breastfed babies stool more, but I can tell you breastfed babies on occasion around 3 months of age will all of a sudden stop stooling. And there's nothing changed, nothing added to their diet, and they'll actually start going once every week. And that's totally normal. And what they'll do is they'll have this huge, soft, loose stool, and that's it. And they'll go like that. I've had kids go every 10 days, and it's very normal. Doesn't bother them, no big deal. And then once you start solid foods, it kind of picks up again. So that can occur. So just to let you know, you don't need to freak out if that necessarily happens. Grunting with having a stool is normal. Drawing the legs up to the chest is normal. Getting red in the face is normal. My partner tells me, when a parent asks about this, says, well, you try having a stool laying down flat on your back with your legs straight. See what happens. It's not going to happen. You got to get in that position. So that's why they draw their legs up. They're going to get red in the face. As long as their stools are not hard, they don't have blood in them, they're not mucousy, then you're okay. Go ahead. What's that for stools? Yeah. That can be very variable. Usually want a minimum of 3 a day, and that includes wet diapers. And actually, as a newborn, the stool output is more important to us than urine output as far as hydration. Kids can actually have tons of wet diapers, and they can be very dehydrated because their kidneys aren't functioning well enough to concentrate their urine, so they'll go and go and go, and they'll be very dehydrated. So most kids we get who get dehydrated, especially with breastfeeding, if you ask the parents, they'll say, well, they haven't had a stool in 2 days. So that's something that's very important. But we want at least 3 a day, kind of as a minimum. The colors of stool you worry about: red, obviously, for blood; black, which can be upper digestive tract, digestive blood; and white stools are abnormal. White stools mean that there's blockage of the bile duct somewhere and they're not getting any bile in their intestine. So those are the 3 colors you worry about. Now, some medicines can cause black stools, vitamins and some things like that, but those are the colors you'd mainly worry about. Green, yellow, stuff like that, don't worry about that. No big deal. I'm going to go overtime here. SIDS, I think that slide's fairly self-explanatory there. I think most people know about SIDS. Obviously, with that, you have to rule out other causes, foul play, abuse, things like that, shaken baby syndrome. The kid who is the most at risk for SIDS is the one who was sleeping on their back and then got turned to their stomach at 3 to 4 months of age. Actually, it's lower risk if they're always on their stomach, even though we don't recommend that because they're used to lifting their head and moving it around. But what happens in those situations is the kid doesn't sleep well, parents are tired, they're fed up. Some grandma says, put them on their stomach. Go ahead and they put them on their stomach 3 or 4 months of age, and then this happens. So that's the biggest risk you're going to get is a kid like that. So we definitely recommend side sleeping or back sleep, preferably back sleeping, although to be a realist, some kids don't sleep at all on their back, so you have to figure out some way to live. And so side sleeping, although it's not quite as safe, sometimes is something that has to be done. But if all possible, you do back sleep, back sleep, back sleep, back sleep. So the mattress we talked about before, firm mattress, no stuffed animals, nothing big in there. Smoking is a risk factor for SIDS, especially with co-sleeping and smoking. Pacifiers have actually been shown to reduce the risk of SIDS. Nobody knows why. It's not a strong connection, but it's definitely there. I can't explain why that is, but it's there. Prevent overheating, not too much bundling. Monitors, those are okay. I don't know if they're going to be necessarily effective. Even those apnea monitors that preemies go home on, I don't know if you have friends or anybody that had a kid with an apnea monitor. No one has ever proven that prevents anything bad from happening. Makes everybody feel good. The one thing it is effective at doing, I can tell you though, is if a kid starts to get sick. Because if they start to get sick, they'll start to have apnea alarms before they get really sick. So it does help in that way, but as far as preventing a sudden death, no one's ever proven that those monitors are going to necessarily do anything. And then tummy time is important during the day just to work on the neck strength and things like that. Oh, to kind of keep them in position? Yeah, I mean, those are okay. And like later on when they get a little bit older and stronger and they're starting to roll a little bit, they make little wedge things you can put them in and things to kind of keep them in position. That's fine to do. I can tell you if you use those things and the kid can roll out of them, then they're probably strong enough to lift their head, and there's not much you're going to do about it. Nobody's going to stand in there all night and roll their kid back and forth. But if they're that strong to do that, they can probably lift their head up. And at that point, if your kid's doing that, then you just have to, again, get the firm mattress, get everything out of the crib, no big comforters, and then you just have to let them be. So, and kids do that at different ages. I have 4-month-olds that roll great like that. I have kids who don't do it till they're 9 months old. So, so everybody does it a little bit different. Can't spoil a baby in the first 3 months. In general, if they're crying, you're going to hold them, pick them up, carry them around. After 3 months, you got to let them cry it out a little bit, which is easier said than done, believe me. It's hard to let your own kid cry, especially at night. 2 minutes seems like half hour. So it's hard to do. But once they get past that point, you got to let them cry a little bit. Now, you're not going to let them cry for a half hour. You're going to go in there after a period of time and do as little as possible to get them back to sleep, and hopefully not run into a big habit of getting them up at night. But up before 3 months, don't worry about that too much. Reasons for crying, again, those are pretty self-explanatory. Never shake a baby. You've got to say that. Most people think, well, I would never do that. I don't see how anybody could ever do that to their kid. I can tell you, if you're up in the middle of the night after a week of being up all night and your kid's screaming and won't settle down, you still don't think about it, but I can tell you, you're upset. I mean, you're at your wit's end. You're tired. You can't take it anymore. You just want your kid to be quiet. And if you think of someone who's there by themselves, they don't have any support, single parent, something like that, a boyfriend who has no, emotional connection to the baby, you can probably see how they could do it. Nobody hopefully is going to, but you can almost see how it could happen because you'll be tired. And sometimes you have a baby who's just a fussy baby, and it can be pretty overbearing. So that's why it's always important to have support, whether it's a spouse, relative, somebody that hopefully can give you a break and help you out with things. So, all right, normal baby movements, Moro reflex, that's the startle reflex where they if they fall back or they get surprised, they kind of shake their arms like that. Sometimes they'll wake themselves up with that. Rooting, sucking, they all do that. Stepping, if you put them down and put their feet on the table, they actually take steps. That's actually a reflex. Some people say, oh, they're trying to walk. No, they're not trying to walk. It's just they automatically do that. Fencing is if actually you turn your kid's head to this one side, their arm on that side will go out straight and the other arm will go up like that. If you turn their head to the other side, it'll do the opposite. Don't ask me why they're made that way, but they do. It's fun to do, but they'll do that. Crossing eyes is very normal until about 3 months of age, and then they should start to straighten out. So they'll be kind of focusing on things, and eyes are all over the place. That's pretty normal. Jerky and erratic movements are very common. The two most common you're going to see is just kind of that jitteriness when they get excited. They'll kind of shake like that in a real fine shake. The other one will be as they're falling asleep. You'll see them kind of jerk a little bit. That's sleep myoclonus, just like adults shake or jerk in their sleep, same sort of thing. And then worrisome movements are, again, not moving one side, arm or leg, rhythmic movements. Seizures in small kids present as either rough, like rhythmic shaking like this, or actually much more common is they actually get stiff. They don't shake at all. So what they'll actually do is they'll arms down like this, they'll stiffen up, put the head back, and they'll usually turn it to one side. That's usually what a seizure looks like in a very small kid. Sometimes they'll shake, but that's somewhat unusual until they get a little bit older. And then a floppy, poor tone, stiff baby. Bathing, won't go into that too much. 2 times a week is plenty. Limited soap on the face. Otherwise, you just clog up pores and cause rashes and stuff. Temperature there is less than 120 degrees. Sponge bathing till the cord falls off. We don't recommend that you use alcohol in the cords anymore. For some reason, again, I don't know why, using alcohol in the cords actually keeps them on longer. And I can tell you it's true, because since we've stopped doing that, the cords fall up much sooner. Usually they fall off at about a week of age. We used to have kids, their cords would stand up to 1 or 2 months when they're using alcohol. So I've never seen that since we stopped doing that. So for some reason, that made a difference. Signs of infection there, again, pretty obvious: redness, discharge, a foul smell. Trimming of the nails, the little nail clippers, you're going to clip their fingers more than you clip their nails. So probably wouldn't use those early on. Nail file works usually fine. I can tell you, no matter how meticulous you are at cutting the nails, they're going to scratch their face. Now, they make those cute little mitts. Has anybody got those yet? Put them on their hands. Those always fall off. They're okay, they kind of look cute. The best thing you use for hands is just socks. You just get a pair of socks and you put the socks on there, and they can't slip them off, and then they won't scratch themselves. So, but those mitts look okay, but they always fall off because they're not tight around the wrist. All right, newborn rashes. These are common things that you get as a newborn that really don't mean anything. Erythema toxicum, that's something to get in the first week of life, usually in the newborn period right after birth. They look like hives. There'll be a little raised spot with a big ring of red around them. And if you actually would take them and look at them under the microscope, they basically have the same cells as hives in an older person. Nobody knows why they get them. They come and go. They'll kind of go from place to place, move around, and eventually they just disappear. Very, very common. Baby acne, that usually starts about a month of age, usually as mom's hormone influence is kind of dropping off. And it looks like regular acne in an older child, just on the face, usually sometimes on the neck and chest. You don't do anything to it. You leave it be, clean it with warm water, it'll eventually disappear. It just takes time. Cradle cap, flaky scalp, comes from overproduction of the oil glands in the scalp. Sometimes they'll give you kind of a yellow, scaly look. All sorts of old-time treatments, baby oil, rub on there, take a little soft brush, rub it off. Sometimes in severe cases, we'll have people just use like a Head and Shoulders shampoo, put it on once a week is all, just kind of rub it in at the beginning of the bath, rinse it out at the end, then use your little baby brush, kind of scrub it off of there. And that usually will calm it down. Cradle cap gets better with no treatment eventually. You don't have to treat it, but most parents can't take it. They have to pick at it, so they usually want something to kind of calm it down a little bit. So you can use that to treat that. Diaper rashes are going to be usually one of two things. It's either going to be a yeast rash or a contact rash. And it's very common for a breastfed baby to get a contact rash because they have so many stools that their bottom's just not used to that contact with that stool. So they'll get a real just red skin basically on the bottom. For that, you just use as much diaper cream as you can use and it'll eventually heal up. Yeast rash is bumps. It's red bumps. And usually you're going to see that in the folds of the skin because it's more moist there. And for that, you use like an over-the-counter, like a Lotrimin cream or something like that. Usually you get in the foot care section. And you put it on 3 times a day for a while. That usually goes away. It's common to see yeast infections after they've been on antibiotics for a while. that often change the flora, the balance of the bacteria of their skin, and they'll cause them to either one, get yeast infection or get oral thrush, get the little white patches in the mouth sometimes. On the last slide, black tear duct, and it's got the fancy name on there. Very, very common. This usually shows up about a week of age, and what it consists of is just a mattering or a discharge from one of the eyes. There's no eyelid swelling or redness. There's no redness of the white of the eye. It's just discharge. And you'll see it more often after they've been asleep. So they'll wake up, you'll wipe it away, you'll stay away for a while, they'll go back to sleep, wake up, and they'll be gooping up again. And all it is the tear duct from the eye to the nose is blocked. It's either blocked or narrow, and it won't drain the eye appropriately. You don't do anything for it. It eventually goes away on its own. About 5% of the cases go to a year of age and actually have to have an eye doctor take a little probe and open it up, but most of them go away on their own. The only time we treat them is if the white part of the eye gets red or the skin on the eyelids gets irritated. Because sometimes just from wiping it off, you'll irritate the eye. Sometimes we'll use some ointment for a few days to calm down the redness. Other than that, there's not much you do about it. Some people recommend a duct massage where you take the finger and kind of rub it at the inner corner of the mouth. No one's ever proven that that works. It makes you feel good like you're doing something, but no one's ever shown that it ever does anything. So sometimes we'll recommend it. It just kind of depends. And then the signs of infection are right there. All right, and I think that's it. Questions? Yes?
I'm having twins. Do you recommend putting them together in the same crib for the first month or two, or do you recommend separate?
No, I think they can be together. I don't think that's any problem at all to keep them together. I think it's kind of neat, actually. They'll often do that in the hospital, depending on where you go. They'll put them in the same bassinet or whatever. Yeah, I don't think I have any problem with that, at least for a period of time. Eventually, in the first 3 months, they're going to be up at night anyway, but eventually you'll probably want to separate them a little bit so they're not waking each other up. But I think initially that's not a problem to do. So.
How many diapers do newborns go through in a day?
Well, it depends. You'll probably go through roughly, at least at the beginning, 12, probably a day. It depends how meticulous you're going to be. I mean, often the breastfed stools especially are very small. And if you're really type A about it and you want it always clean, you could even go more than that. Because it never fails. You're going to change one, put the one on, they're going to go right away again. So you kind of like try to time it to, changing them right after they eat and things like that. But you're probably going to go through 12 a day, somewhere in that range, which is a lot. Yeah.
For how long would that be?
Oh, for how long is that going to be? Well, it depends how long they have stools that often. Sometimes they decrease the number of stools as they get older. So, and so it's hard to say really how long that's going to last. The good news about the small ones is they're cheaper and you get more per bundle. But as you get older, they get more expensive and you get less. So, yeah, go ahead. Yeah, it's going to be roughly when they eat, because a breastfed baby is probably going to eat every 2 hours. And it kind of depends. I mean, some kids you can get by with changing them a little less often and they'll do fine. They won't get a diaper rash. There's some kids, they'll just get any little stool on their bottom and they're getting a rash. And so some kids you have to be a little more meticulous on changing their diaper. The hard part there is at daycares. Sometimes at daycares, I think they let them, go a little bit longer, which is understandable if they have a lot of kids to take care of. So sometimes kids will have rashes during the week. They'll come home for the weekend. The rash is gone. They'll go back during the week. They'll get their rashes again. And that's kind of just part of life.
Yeah. On the bumper issue, I know I've seen some that are made out of netting, so they're like breathable. Is that bad, good, safe?
I've never heard of a netting one. I can't tell you for sure. I still think they could get tangled up in it, whether they could breathe through it or not. So I think it's something you would still want to remove. I mean, because it's really not serving a purpose necessarily. You're not worried about them sticking their arms through the slats of the crib because they don't ever get hurt doing that. And they almost never wake up. You'll find them that way, but they'll usually sleep right through it. So there's no reason to have it necessarily. But they're nice looking though. We had one. I had them for my kids too.
my sister gave me a bunch of her old bottles. Is it okay to use those, or should I just buy new ones?
You could probably use them, but you'd have to boil them before you used them. Usually we recommend, even when you buy new bottles, is you boil them the first time you use them, and then after that you can just wash them in the dishwasher, or wash them in hot soapy water, stuff like that. But if that's something that you feel comfortable using, I think if you boil them and the first time you use them, then you'd be fine.
Any recommendations on introducing a dog to a baby?
I knew I was going to get this question. I was even going to put it in my presentation, but I decided not to. For the most part, dogs are pretty good. In fact, most of the time dogs are scared of them, and they kind of just stay away, even though they'll kind of get close and sniff and move away. If you see any aggressive tendencies at all, of course, you'd have to think about doing something different with the dog. The only thing that I've seen, and we actually did that with ours, is we took a blanket to the hospital. One of the ones you actually used it with the baby, and then you brought it home and let your dog kind of hang out with it and smell it and sniff it, just to get used to the smell of the baby. And then when you get home, you just have to be a little bit careful with the baby on the floor a little bit. But for the most part, I think dogs kind of understand a little bit, what a baby is. It's something smaller than them, and I think most dogs are pretty good with them. What kind of dog do you have?
He's a lab.
Oh, labs. Yeah, labs are fine. They're friendly to everybody, for the most part. But that's the only thing I'd recommend, maybe taking a blanket and bringing it back home. Kind of have them use it the first day and then bring it home the second day.
What about cats?
Cats I don't like, so you just got to get rid of it. No. The main thing with a cat, and actually this probably goes for dogs too, is you probably just need to keep them out of the room they're in. I don't think they're going to get smothered or anything, but it's mostly from an allergen standpoint. Other than that, again, I think cats are fine. Cats are kind of aloof anyway. They're kind of their own, they go on their own little way. They kind of stay away from people anyway. So, they'll come on your lap, but they're pretty independent. So I've never actually had any problems with a small child and a cat, I think, other than a little nip or something like that. By far and away, it's a dog. The time you really need to worry about dog bite is when they're about 3, right when they're about eye level to the dog, because of course dogs don't like it. And of course kids, what they want to do is hug it like they'd hug a stuffed dog. So they want to get face to face. That's where you're going to run into trouble. And dog bites in the face don't turn out good. They almost always get infected. They're going to scar horribly. It's just something you want to stay away from. So, did you have a question?
Oh, it was a cat question. He took it.
Oh, the cat? Oh, 2 cat lovers.
Yep.
Okay. Yeah, go ahead.
My friend told me that you don't, she's had 3 kids, said that she found out she didn't really need cribs, that she just used the playpen as the crib for the entire time, and then just kept using the playpen and never bought a crib.
Sure, sounds good to me. Yeah. You just have to be careful with the bottoms a little bit, because some of those kind of sag a little bit. So you need something firm in there, either a small mattress that keeps the whole thing firm. Don't want anything soft or squishy. But yeah, I've had other people use a playpen, and that's it. And then bassinets, most people use those for a while just because it's more convenient with nursing. Eventually, you tend to get to a crib. But yeah, I've had people actually do that. I've actually had people use their car seat and have them sleep in their car seat for a while. So, because they wouldn't sleep any other way. So they just clip them in like they're in the car and just put the handle back and put them next to the bed and let them sleep in the car seat. I don't think it's, I guess it'd be safe, if something happened. Tornado came and threw them out, they'd be in the car seat. But yeah, some people will do things, because it's hard, because I can tell you most kids would love to sleep on their stomach. If they had their way, they would all want to sleep on their stomach. You just tell when we get them in the office and we're looking at them, we put them on their stomach to see how strong their neck is. They get those arms in and they snuggle up. They would all like to do that. So, but the risk isn't worth it. It's obviously a devastating thing, and it's just not worth it to make that risk.
In your room, you have a bassinet, how long should they stay in there?
I think that's up to you. When you're talking about spoiling them up to 3 months, beyond that, you're going to start to let them cry it out, and it's really hard to let them cry it out after, when they're in your room 2 feet away. It's much easier to do. Oh, you want a couple days?
I mean, how long? I don't.
Oh, bassinet? No, you can do that for months. Again, it's for, again, convenience from the mom, not the dad. Dad's sleeping through everything, or at least faking it. Believe me, you guys will get good at that, by the way. Getting that one eye open, just laying real still, like you don't hear it. Yeah. It's an art. So anyway, yeah, you can do it for 2 or 3 months. But after that, it's just hard to let them cry things out when they're right next to you. It's just very difficult. The hardest one, and the ones I feel sorry for, are the people that live in apartments. Because you can get kids that will scream, and of course, people are getting mad next door. And so they have to go pick them up to get them to stop, where you're just teaching them to cry, basically. But what choice do you have? The neighbors, you don't get them mad at you, you don't want to get kicked out of your apartment, so you kind of get stuck. So that makes it a little bit difficult. Anybody else? No? Apologize for my pager. I think I was actually on call tonight and I didn't know it, so somebody's going to be mad, but we'll see. All right, well, I guess that's it. Only 15 minutes over.